Good evening. It is week 3, Respiratory 259. I'm Tim Dunkley, your instructor. It's October the 17th of 2017, and welcome to this week's live lecture. We're halfway done with the mod, and congratulate yourself. Overall, everybody's looking great, doing a good job. I enjoyed, once again, everybody's discussion posts from last week, and the learning opportunities you've been able to get at your clinical sites. That's always a fun thing for me to look at and to watch and to read, I should say, and I enjoy that. And we made it through our first round of PI forms. There's some heartburn over some of the PI forms not hitting that 300-word minimum. Please don't sweat that. You don't have to resubmit. Everybody's signatures looked fine. That was all good. Just keep in mind, like I said in previous lectures, and it says at the top of the form that needs to be a 300-word post about your physician interaction. And no big deal. You don't have to resubmit your DocuSign form. Just email me your summary, and you'll get your points. With this course, with these clinical courses, it's either all or nothing on those PI forms. It's either 0 or 167. So once you get that into me, I'll get that graded, and several of you already have. I got that fixed, and no big deal. But also keep in mind that with those PI forms, that it's time to start working on your next one. Get that submitted because next time we'll be up against the end of the mod, and so you'll want to certainly have that in early or certainly on time, so that you can not have any issues or any hiccups with your final grade. They always want us to get those grades turned in on as soon as we can past the closing of the mod, and so we don't hinder that. If you will get all those forms turned into your preceptor to get signed and moved up the chain, then I can get all that graded, and that will speed things up for you. Excuse me. So that's just kind of the housekeeping things I had for you this week. Like I say, some good experiences, some good questions, and some good interactions, and I appreciate everybody participating on that. And I hopefully can provide some answers if you do have questions, either from your discussion posts or something you had with your physician interaction, or as you've done the classmates scenarios. So let me be a resource to you. Let me help you out. I'm happy to do so. If you have any questions about your grade thus far or any other issues, also don't hesitate to reach out to me and let me help you and do those things that you need to put you at ease with where you're at with the class and the course. But essentially, if you get your discussion posts done and get your DocuSign forms turned in, you'll do absolutely fine with this course. But like I say, if there are any issues or you have any concerns, get a hold of me. Also, if you see anything in your clinical time that you have questions about, I think it was last week Melissa asked about trait care. So I'm hoping to get together something that we can go over some trait care stuff, or at least put in the discussion post, and see if I can facilitate getting her down the road to the long-term acute care to have her a little more experience with tracheostomy. So the hospital I work at has a LTAC nearby, and a lot of times our patients will get trached and they'll ship them out soon thereafter down to the LTACs. We rarely really hang on to trachs at our facility, and that seems to be kind of a trend nationwide as a cost-saving measure for the acute care hospitals. So anyway, I thought if we have time, we'll go through some classmates scenarios once again. And like I say, if you have any requests, feel free to fire in those requests. We had a request last week to cover a particular classmates, and so happy to go over those. And I assume that all of you that do the classmates go through the scenarios and listen to explanations, and I hope that my explanations and my thought process will help you as well, kind of prepare and get you in the mode as you are nearing completing and taking your TMC exam. Okay, so this particular patient is named Shelly Ann Bazin-Atkins. We're a respiratory care student on a clinical rotation assigned to the medical intensive care unit at a small community hospital. We'll be supervised by hospital staff therapists that we have not worked with before. Yeah, but give the report on Mrs. Bazin-Atkins. A 37-year-old female was admitted for severe asthma 24 hours ago. She weighs 135 pounds, which is 61 kilos, and is 5'7", 107 meters tall. Mrs. Bazin-Atkins is orally intubated with a 7.5 ET tube and is currently being mechanically ventilated with the following parameters. So like I've said before, anytime you get any sort of initial parameters, make a mental note. You can write those down if you see something that you want quick reference to. You will have scratch paper with you, but you can also click on the simulation history, and that'll show you any of the previous screens as well. So if you don't remember something, you can look back at that, and certainly I would recommend that. You don't want to get yourself into a situation where you're guessing or trying to guess. So having said that, our settings here is we're a SIMV volume control, set tidal volume 450. We have a set rate of 16 breaths a minute. FiO2 is 45% and 7 a peep. So pretty standard settings there if we're going to run SIMV. I'm not a huge fan of SIMV, but you will see SIMV on your test questions. So instructor asks us to evaluate the patient, the clinical status, and what would we recommend to evaluate. So as we've talked about before, we're going to select as many as we consider indicated in this section. The first thing to look at, and I recommend on every patient that we assess, is we always have our stethoscope on. And so we're going to listen to our breath sounds. High-pitched wheezes, so red flag there. We definitely need to start thinking about if we have wheezes that it's probably treatment time for this patient, but we'll keep moving on down. Diagnostic chest percussion. So we're checking for tympany and that sort of thing. And it's tympanic bilaterally. So that tells us that the patient's, probably air trapping. And so tympanic bilaterally as we tap, the things are tight. Intracranial pressure, nothing indicates that this is a trauma patient or a bleed patient. So I don't think we're too worried about intracranial pressure tonight. Vital signs, I'm certainly interested in that. Temperature's 37.2, so that's normal. Pulse is up. Respir, she's breathing just over the vent. Remember, we have a set rate of 16, she's breathing 19. And blood pressure seems to be okay. Sputum culture and sensitivity. She doesn't indicate that she has anything growing, but so the instructor disagrees because she's normal, her normothermy, she's normothermic and that sort of thing. So I was a little too quick to click on that one. Heart sounds, and nothing indicating that she has any sort of murmur issue there. RSBI. We look at a rapid shell breathing index when we're getting ready to extubate somebody, and so it's nothing I'm interested in SIMV. I'd be more interested in that if I had them in spontaneous mode. Also pupillary reflex, back to the neuro thing. I don't think I'm too interested in her reflexes because nothing indicates to me that she has any sort of neuro deficit going on. DLCO is a diffusion test that we do in the pulmonary function lab. It's nothing that we can test while the patient is on mechanical ventilation. So I'm not too worried about that. I'm not going to pay attention to that. Platelet count, again, nothing indicating that she's bleeding or issues there. Appearance I'm interested in. So she's diaphoretic. She's using expiratory accessory muscles. So that tells me that she's air trapping. That when she sucks in, she's using expiratory accessory muscles to try and push that air back out. So we need to fix that. Serum CBC. She's nothing indicates that she's got a bug or that she's septic or there's any sort of anything growing on her. So I'm not going to worry about that. MRI of the chest. Again, if we were going to do a diagnostic scan of the chest, it would certainly be a CT scan there. So not worried about that. We look at her saturations. 95%. I think a blood gas is always indicated. So fairly normal there. Our ventilating pressures, PIP's 38, plateau's 24. So think to yourself, what does high PIPs and normal plateaus tell us? That tells us that there is some resistance in the airway. And so every other indicator with the use of the expiratory accessory muscles, and certainly what we're seeing with the breath sounds still gives credence to we've got probably some air trapping issues. Verify function of manual resuscitator. I think that's always a good idea on your first round to check that out. Make sure that it's present, working properly, ready to go in case we do have accidental extubation, things of that nature. Chest X-ray report, I think that's always indicated. Flattened diaphragms bilaterally, something we'd certainly expect with a asthmatic and our graphics. they agree. They don't show us the graphics, but the instructor agrees that we should be interested in those. So anytime you have someone working and that we have someone that is wheezing and potentially air trapping there, we look at the graphics and see if we're returning back to baseline, and that's going to tell us if we're air trapping. So let's move on to the next section. We'll go from there. Aha, so there's our graphics. And yeah, it looks like we've got some air trapping going on there. So we definitely want to address that. So the instructor would like us to evaluate the graphic below, and the graphic indicates which of the following. Reduction in static compliance. So this is just showing us flows. I see flows and pressures. I don't see any indication of volumes here. So there's no way to really have an idea of the compliance there. Alveolar collapse, I don't see any indication of like a critical opening pressure. Auto-cycling of the ventilator. Auto-cycling is going to be more of a sawtooth, quick type chatter. Of the graphics, I don't see that. Patient asynchrony, I don't see any indication of asynchrony here. Air trapping auto PEEP. Notice where the arrow's pointing, that we look at the inspiratory side, the breath goes in, and then as we transition to the expiratory side, that never returns back to baseline. And so we have that little gap there, which is indicative of auto PEEP or air trapping. And then the bottom is excessive flow. And I don't see any peaking out of excessive flow. So certainly we're air trapping, and our assessment on the previous page certainly backs up what we're seeing there. So the instructor asked for a recommendation for us. And so what would we recommend at this point to make our determination based on our assessment and our previous graphic? So what are we going to do to fix this? Increase the tidal volume 750. So we're already have pips of 38. So that's a problem. So if we try and push more volume in there, that's not going to help our situation. If we increase our ventilator 8 to 18 breaths a minute, we're already at 16, which is I feel like on a high side anyway for a set rate, especially in a patient that we have air trapping issues, because the faster rate we set, the less time opportunity for a wider IE ratio and longer expiratory time. So I don't recommend that. Perform an inline treatment with a SABA, which is a short-acting beta agonist. She certainly is wheezing. We've got air trapping. I think that we probably need to go to that. Pressure control SIMB. Something we could consider pressure control as a lung protective type strategy, but still we're not over kind of my threshold is 40. We're dancing around it. We're at 38, but I think if we can try a treatment and maybe mess with our breath timing a little bit, we can fix this patient. But that's something to consider down the road if we're still having trouble. Insertion of a chest tube, nothing indicating that this patient has a pneumothorax. So I'm not going to do that. Increasing the PEEP to 10. I don't see any indication of that. They're oxygenating fine. Decrease the expiratory time. Decreasing the expiratory time is absolutely the last thing you would ever want to do. We need to figure out a way to lengthen and extend out our expiratory time to eliminate this air trapping issue. So I don't want to do that. And then suction use the Coude, and I don't see much indication of needing suction here. So let's give a treatment, and the instructor agrees, so let's move on. The instructor is concerned that bronchodilator therapy might not eliminate the auto PEEP. Which alternative intervention would you now recommend? So we can increase the rate, and as I said on the previous slide, if we start increasing rate, that's going to tighten up our IE gap, and we don't want to do that. If anything, we want to drop the rate. She's already breathing 18, 19 on her own, but if we were in control breaths and we drop the rate, then that's going to widen out, give us longer expiratory time. So I don't want to increase the rate. Increasing the expiratory time, that's what we're looking for. That's what we want to do to allow for that gas to exhale, or to allow that patient to expire that gas. So that's certainly something I'm interested in doing. Next one is, we'll go through all these just to make sure we made the right decision. The next one is to decrease the inspiratory flow. If we decrease the inspiratory flow, then that makes our I time longer and our E time slower. So we don't want to do that. If anything, we want to increase the inspiratory flow, and that'll make a faster breath in to the patient quicker so that we can have a longer expiratory time. Decreasing the PEEP, that's not going to do anything to eliminate auto PEEP. And increasing the tidal volume is going to do nothing but increase our peak airway pressure. So I'm going to go back up to increase the expiratory time and move along from there. The instructor is concerned about the PIP reading of 38 and asks us to recommend a lung protection strategy to move the PIP below 35. So what would we recommend now? So we have an inspiratory pressure hold. So that'd be a pause on the top. That's not going to do anything to affect our peak pressures. That's a trick to increase your mean airway pressure a little bit if you're having oxygenation issues. So that won't work. Time cycled breath. We're already on a set rate of 16, and this patient's breathing, 18, 19. So that's not going to do anything for us at present. It decreased mechanical dead space. Blood cast was normal, so there's no need to change our dead space to help with more efficient ventilation. Excuse me. Change the source gas to Heliox. That's something that we certainly can consider. Heliox and helium is a lighter gas, so we have more laminar flow. And certainly in patients where you have an air trapping issue, that's something that you can certainly consider doing. And lastly was pressure support ventilation. SI and V are still getting spontaneous breaths with pressure support there. And so your patient's benefiting in those spontaneous breaths with getting that normal breath cycle and the breath timing that they want. So I don't think that that's really going to do much to help our overall PIP situation. It would help it somewhat, but we still need to deal with what's the cause of this, which is airway resistance. And so I'm going to start using Heliox on this patient and go with that, and that should help our patient. So information gathering as we look at this. 14. I clicked on 2, quick, not thinking or talking about it, and I got dinged on those, so our net score was 12 there. Maximum score is 15, passing is 11, so we passed that. Decision making, total points selected, we got 8, no negatives. Our net score was 8. That was our maximum score. Passing was 6, so we did well on that one. We can review that one, but I think we'll just do another simulation here tonight, because that was pretty straightforward, and I was able to talk through most of those. Let's see what else we want to do tonight. Okay, so this sim is we're a respiratory care student, medical ICU, 350 bed suburban hospital. We're with our clinical instructor with staff respiratory therapist that we have not worked with before. Following the shift report, your instructor tells you that your first patient will be Mr. Paul Lyer. You now proceed to Mr. Lyer's room. Upon entering Mr. Lyer's room, you observe the patient is intubated and placed on a ventilator. Appears to be resting comfortably. The instructor asks us to assess Mr. Lyer's present clinical condition and report our findings. Excuse me. Mr. Lyer is 65 years old. He's 138 pounds, 63 kilos, 5'7", 170 centimeters tall. Excuse me. You observe that the ventilator is set at the following parameters: volume control, SIMV, tidal volume of 550, with a respiratory rate of 16, FiO2 is 45 a peep. So nothing too crazy there. Pretty straightforward settings there. Certainly showing the love of the MBRC has with SIMV. Again, I'm not a huge fan of it, but there will certainly be SIMV questions on the exam. Excuse me, I'm losing my voice here, so we'll stick with it. So we need to select as many as we consider indicated in this section. The therapist with us wants us to is asking what we need to assess on this patient. Let's see if I can get my voice through this here. So first of all, breath sounds. Always want to take a listen. Hoarse crackles, diminish on the right middle and lower lobe expiratory wheeze. So that tells us we've got stuff cooking there. Potential issues there. And so anything outside of clear bilaterally, something to consider that we're going to deal with. Peak airway pressures, 28. So not horrible. Not crazy peak pressures. Remember, our target for protecting lung protection, etc., is an ARDSNet that we want to keep plateau pressures below 30. Sputum production, based on our breath sounds, I think I'm interested in that. Moderate amount of yellow, mucoid secretion suction. Okay, not surprised by that. Drug toxicology, not too interested in that. Nothing indicating we have an issue there. H&P admitted for pneumonia. So if we're getting yellow, we definitely want a sputum culture. And it's pneumococcal pneumonia. sensor him so we can see what's going on there. And so he's sedated. He's on a propofol drip. CBC is whites are 16,000. So we'll want to take note of a trend there. H&H looks okay. P50 level, that's just a 50%. The amount of pressure to get a 50% saturation on myoglobin. And so we're not hypoxic, we're not having trouble dealing with oxygen and dissociation curve stuff. So I'm not too worried about that. Vital signs, temperature's up. So red flag there, pulse is up. No spontaneous respirations. And blood pressure is not too horrible. The cardiac enzymes, nothing indicating that he's got a heart issue going on. I'm not going to worry about that. Bedside pulmonary function, that's a little tough to do because the guy's intubated, so I'm not going to do that one. 12 lead EKG. Again, no indicator of heart issue, so I'm not going to worry about that. General appearance, he's pale, digital clubbing noting, 1+ pedal edema. So this is more of a chronic guy with that digital clubbing. Chest X-ray, infiltrates right middle lobe and lower lobe with flattened diaphragms. So that tells me a COPD component here as well with the infiltrates from the pneumonia. Pulse oximetry, satin okay, and our blood gas. CO2 is elevated, but we're compensated. Our bicarb's up to 35, so we got a retainer here. And at sea level, that PaO2 would be on the low side. Keep that in mind that the MBRC hospital that's going to be in your scenarios is going to be at sea level, so we expect a little higher PO2. So that's about the only thing jumping out at me there on that arterial blood gas. So let's move on and look at our next situation here. Our instructor would like us to recommend a care plan, and based on our assessment, which of the following would we choose to include? So we're growing stuff. We've got a culture back, and we've got color secretion. So I'm actually going to go ahead and administer an antibiotic. Handheld vibratory PEP, he's intubated, so don't need to mess with that. Respiratory rate to 18. Let's just look at what our current rate is at. Oh, it's 16. And our blood gas, our CO2 is 62, but we're still 736. So in my mind, we're okay for that. Percussion partial drainage. There's some infiltrates there. So let's try that. Change mode to PCAC. We're not having trouble with pressure issues. Our CO2 is up. I don't think we want to decrease our tidal volume. Chest wall oscillator. We are doing the percussion and increase the FiO2. I think we'll do that just because your PaO2's low, but it doesn't want us to do that just because it looks like he's had COPD tendencies. So just testing the water with that one to see how concerned they were about the PaO2 of 60, which it doesn't appear that they are with this particular patient. just because of the flattened diaphragm, etc. That makes us think that he's a COPD, and they're not too worried about giving him a bunch of oxygen. 2 hours later, the high pressure alarm is sounding on the vent. The instructor directs your attention to the ventilator graphic. You note that the high pressure alarm is set for 38. The exhaled tidal volume is 265. The patient's pulse is 128. Blood pressure is about the same. Pulse oximetry is down. Instructor asks us to make recommendations to correct this. Perform a leak test on the vent. Not interested in that. Adjust the FiO2 to 80. So yeah, we certainly turn up our FiO2. And oh, they don't want us to do that because 88% with a potential COPD, so I see what they're thinking there. Breathing treatment, that's going to help with our pressures. So we'll give them a breathing treatment. We certainly can listen to them. Coarse crackles and wheezes, so that SABA was indicated. We've got high airway pressures, so I don't want to increase my tidal volume. But another way to fix that is if we need to give suction this patient because we've already had secretion issues in the previous slide. So let's do that. And we go ahead and suction that patient. Five days later, Mr. Lyer is more alert and receiving less medication. He's still not breathing spontaneously. If blood gas is obtained with the following results: pH of 737, CO2 64, PO2 95, saturation 96. Bicarb is 36. Still volume control, SIMV. Tie volume 550. Rate of 16, FiO2 of 40. 5 centimeters of PEEP. Our instructor asked for a recommendation on this time. Add pressure support. They are in SIMV, but he's not breathing spontaneously. So if he's breathing spontaneously, I would certainly consider those spontaneous breaths need to be augmented with pressure support. But since he's not breathing spontaneously, it's nothing that I want to dial in because it's not an issue at present. Decrease the PEEP to 0. Never really indicated that I can think of to change our PEEP to 0. So I'm not going to change that. Maintain current settings. I think that overall that's a decent gas, but the PaO2 is high, and so I think what they want us to do is drop that oxygen because they've made a big deal on the previous slides of disagreeing with us trying to titrate that oxygen because they're playing the COPD card with too much oxygen. And it looks like the instructor agrees with us to drop those saturations. So now our instructor asks us to perform a patient ventilator assessment, and we note the following: volume control, SIMV, tie volume of 550, rate of 16, 35%, 5 PEEP. PIPs are 27, plateaus are 19, pulse oximeter is 91, spontaneous volume is 200, spontaneous respiratory rate is 10 a minute, heart rate is 110, blood pressure 129/86. Breath sounds, bilateral fine expiratory wheezes and crackles. The tube is taped at 23 on the lips. You also note high pressure alarm to be set at 55. And the low exhaled minute volume alarm is set at 7 liters. Which of the following actions would you recommend to the instructors? So what's the issues? A couple of things that jump out at me is that spontaneous tidal volume of 200 is pretty low for about anybody out there that's an adult. So that's something to think about. The other thing that's jumping out at me is that high pressure alarm set at 55. That's a big deal. That's way too much pressure to be allowing to allow that vent to put onto the airway. So I think I want to address that because that is way too high. So initiate a spontaneous breathing trial. Don't know if he's quite ready for that based off our low spontaneous tidal volume. Chest X-ray to verify tube placement. Nothing's coming at me that we have a misplaced tube there. So I don't want to advance the ET tube until I know. I definitely want to decrease that high pressure alarm to 37. And that's what they're looking for, was that high PIP there. So as we look at our rundown here, for our patient, Paul, total positive points of 13, no negatives. Our next score is 13, maximum possible score is 13, and passing was 9. So as far as information gathering, it looks like we hit all of those. Decision making, positive points 13, negative points 2. Both of those were oxygen. They wanted us to remind us that we were COPD, to not worry about oxygen with this guy. So our net score was 11, maximum possible is 14, and our passing was 11. So let's look at our simulation review here, and just go down the list and see if we missed anything that they thought was interesting or that we would need to know. So we got our blood gas, we got our sputum, CNS, vital signs we were on. We were right, not worrying about drug tox and cardiac enzymes. Vital signs and sensory, HMP we were good on. P50 and 12 lead, nothing was indicating oxygen absorption issue or a 12 lead. Breath sounds, pulse ox, CBC, general appearance, AP X-ray. Pulmonary function, couldn't do that because patients on the vents, that'd be tough to do that. We were curious about our PIPs and our sputum production, so all that was good there. On this particular screen, we're supposed to recommend some intervention or care plan based off of that, a previous assessment. Increase the rate to 18, we were okay with on that. They didn't want us to increase the FiO2, and being that he has the tendency of a COPD. So I get that they ding me for that one because they were okay with that lower, with that his PaO2 was in the 60s, and they were okay with that because of his COPD history. Antibiotic they're okay with. Decrease in tidal volume, we didn't want to do that. We didn't want to go pressure control, and we didn't want to do PEP because he was intubated. So we did do percussion and post-dural drainage. And then I thought about the chest wall oscillator, and that's either like the Bronchotron or also the Metanep can do that. And you can put those in line with a vent. And I figured we were doing percussion and partial drainage, but it looks like they wanted us to select that chest wall oscillator as well. So even though we're doing one thing, it looks like we need to think about doing other things or everything to manage that patient. So they give us a little graphic there. It's showing us that with not a bunch of flow, that we're jumping up pretty high with our pressure on that loop. So we didn't want to increase our tidal volume. We wanted to give the treatment and listen to breath sounds, and they didn't want us messing with the FiO2 with him being a COPDer. They were okay with us maintaining sats of 88. So good reminder and thought for me on that one. Moving on, looking at our patient now. He's doing better, and we drew the blood gas, and because of the COPD, our PaO2 was sitting at 95, and that seemed to be the best choice here. We definitely don't want ever peeps to zero on vents. We didn't want to maintain those settings because we knew our PaO2 was high. Didn't want to increase that rate because I think we were okay with a pH of 737, so we didn't want to change that. And he wasn't spontaneously breathing, so we didn't want to add pressure support. So we were good with that one. The problem that we had with this one, as we reviewed, we chose to decrease the high pressure alarm to 37. If you recall, looking up in there, that it was set at 55, and you're just asking for for trouble with 55 on our high pressure alarm. Keep in mind that when we set those high pressure alarms, that's not only telling the vent when to activate the alarm if the pressure exceeds that, but it's also telling the ventilator that that's the pressure that we want to have the safety valve set at. And so any pressure above that, it triggers the safety valve and opens up the exhalation valve and dumps the excess pressure out so that the patient doesn't see any pressure above that. If we set our high pressure alarm that high, that patient's going to see all that pressure. So if they cough or even things like hiccups or get some secretions or resistance in the airway, and the vent and our compliance drops or something like that, and that vent tries to push that breath in, it's virtually going to allow that pressure to run up to 55, and that airway and those poor lungs are going to see all of that pressure. I rarely set my vent pressures above 40, high pressure alarms above 40 for that reason, because we don't want to do any harm. So keep that in mind. Keep that in mind when we set those, that we do want a little bit of movement there if we do have some pressure spikes. but we want to keep that set so that that patient doesn't see too much pressure. So that was the best answer there, was to drop that high pressure alarm down to 37. And that's what the instructor wanted from us. So that's just a couple of simulation results, or excuse me, so a couple of scenarios to run over or run through. And I hope that was enjoyable for you and helped you to think about what the MBRC is looking for in these various scenarios, and hopefully me talking through those can be a help to you as well. I appreciate your time tonight. If you have any questions or issues, please let me know. I look forward to your discussion posts forthcoming this week. And also I look forward to next week and helping you making sure you get those DocuSign items in before the end of the end of next week. So if you can, please start working on those this week. If you have any issues, please let me know and let me help you get those taken care of. Otherwise, we'll be back online with you same time, same place next week for a week 4 lecture. And if there's anything you'd like me to cover that you see in your clinical time in these life lectures, please don't hesitate to contact me. Thanks for your patience tonight with my voice going away from me, and so hopefully I can get that taken care of and won't have to be coughing so much next week. So I appreciate that. I hope you all have a good night, and we'll see you again soon.